What's really interesting is while mainstream medicine has actually kind of shied away from a lot of the regenerative medical products, dentistry never did. And dentistry has been using PRP, PRFM, and PRF all the time. Tonight, I wanted to talk about some basic technology and information that you can use to be able to do joint injections, to understand corticosteroids, like how to use steroids, when you should use them, et cetera, for joint injections and for soft tissue injections. And then also how you can use a patient's blood, buy a centrifuge that costs you around $300, and you can actually start to use regenerative medical products that are derived from patients' blood to actually heal them and to do some really amazing things. The stuff that we're going to talk about is not hard. You just have to be familiar with it. And to be quite honest, a lot of physicians are not that familiar with it. There's not a lot of nurse practitioners that are familiar with it. And one of the advantages that you have as being a CRNA is that you have such a diverse skill set. Everything we're going to talk about tonight is easier than installing a central line. It's easier than floating a swan. It's easier than managing a cardiac case. And you can make some differences in people's lives that are profound with the technologies we're going to discuss tonight. So that's why I'm so excited about talking about it and sharing it with you guys, because I want you to know that should you desire, you have the ability to have a whole other skill set that you can use. And if you guys listen to the Medical Entrepreneur podcast, you know that I'm a big proponent that everyone in what I call mainstream medicine, working for hospital companies, for anesthesia groups, for whatever, I personally believe that everyone who's working in mainstream medicine needs to have, at the very minimum, kind of like a side hustle, have some kind of other way that you can generate revenue should you need to. And this other way should be cash-based and ideally not based on insurance. If you want to deal with insurance, you can. It's a whole, it's a whole different ball of wax there. But what I would recommend, and there's plenty of cash-based business, but like there's so many people now more than ever before that need your help, that have pain, that have disability, and there's just nobody out there to help them. I mean, there's not enough doctors out there to help them. Most of the doctors that are out there in the system, they have other priorities based on the way that they're set up with hospitals that may not result in the best things happening for patients. Whereas one thing we do know all the time is that for all of us here on Platelet CE, you have the ability to deliver these procedures and help a lot of people. I packed a lot of information in this, but my goal is today for you is like, what are you guys going to get for tonight? We got a couple of things we have to discuss in order to reach our educational objectives for this evening and get our CE credit. That's going to be discussing what glucocorticoid agents are. These are the common steroids that you see that are used for soft tissue injections, joint injections, et cetera. We'll talk more about those. And then understand the role and the limitations of corticosteroid and soft tissue injections. We'll also talk about using local anesthetics with those corticosteroids. It's another learning objective. And then what my favorite part is that after we discuss those things, that will basically tell you everything that mainstream medicine does. This is what, when you send somebody to an orthopedic surgeon that's in, a hospital or clinic that's controlled by mainstream medicine, this is the treatment they're going to get because it's what's approved by the insurance, right? And then we're going to talk about how, basically things that you can do very simply and very effectively, very cost effectively, that you can do to generate regenerative medical products that you can use to actually heal other people. And what I mean by that is there is scientific data showing that these regenerative products, if they are used in different procedures, have had massive effects. And we'll show you some of the data and graphs. It's really cool in terms of actually helping people overcome their problem, whereas steroids are more of a temporary measure. So, and it's good to know both of them. And I think it'll be very exciting for everybody. So one of the things that I see, and we'll talk more at the end of the thing, is that there's huge opportunities for this all surrounding you. And we'll talk more about how to find those, et cetera. If you want, if you don't want, that's fine too. So just let me know. All right. So talking about glucocorticoid injections for soft tissue injections and intra-articular injections. Wow, what a mouthful. Basically steroid injections. As you might know, glucocorticoids are from the adrenal glands. They're naturally producing the adrenal cortex. And they're potent anti-inflammatory and immunosuppressive properties. There are also synthetic variants that are used in many of the therapeutic conditions. Well, that's kind of the ones that we use. So here are the most common glucocorticoids you might see. So for example, you have triamcinolone. It's probably the most common that you'll see for, especially for joint injections. If you were to wander into an orthopedic surgeon's office or into a sports medicine physician's office or into a PM&R office, the most likely steroid that they would inject you with would be triamcinolone. It's the most common. It's very powerful. It's very effective. You also have methylprednisolone, and it's usually typically used for larger joints, although triamcinolone is kind of a go-to favorite. You also have betamethasone, which is kind of various. It usually is not used that much because its cost is actually much higher than the other two, just in general. I'm not sure exactly why that is. And then you have, of course, dexamethasone, which is the only non-particulate steroid of glucocorticoids, meaning like if you look at most steroids, so you can tell this is a particulate steroid because look how white it is, right? So whenever you see somebody injecting a syringe full of white stuff, it's very particulate. The reason why you can see the white stuff is that the particle sizes are so large they can have to be seen by the eye. Now, if you take dexamethasone, which you have, in your anesthesia carts, right, and you look at it, it's clear. And dexamethasone is non-particulate, and there's advantages for particulate and disadvantages. But you can tell the difference between the two because the non-particulate are always clear and the particulates are always white. So in this case, this guy has a little bit of mix of local anesthetic in here too. So that's why you can see the particle sizes are kind of larger on the top than the bottom. But jumping back, basically, these are the most common ones that you'll see. There's no, I guess, right or wrong. So some people say, hey, I love to use methylprednisolone. Some people say, hey, I love triamcinolone. Most people use dexamethasone for intraspinal injections. And the reason why is that particulate steroids, the white steroids, have been known to cause artery spasms. And in the spine, the biggest fear is that you would inject a steroid, like maybe for an epidural steroid injection. And if for some reason that steroid ended up heavily on some of the arteries in the front of the spine, you can get a watershed effect where you basically get essentially an artery to spasm, cut off blood supply to a large portion of the spinal cord, and it can cause obviously some major damage. So typically the white steroids are not used in anything in neuraxial, right? So anything inside the spine. Now that being said, if you go back, 15 years, it was actually common for people to use the particulate steroids in epidurals. And to be fair, though, in the past, people did more of what they call, kind of midline approach, or what they call interlaminar versus transforaminal, which is one where you go on the side. And so because it was more interlaminar, has a better spread, same way we do traditional epidurals, it was probably a little safer. But there were many cases where people actually had damage to their spinal cord from particulate steroids, just case reports. And so that's why we typically don't use them in the spine. However, in other countries like India, they still do a lot, just something to keep in mind. So how do these glucocorticoids really work? Here's actually a picture showing how the glucocorticoids actually work. They actually come to the cell. They actually bind to basically chaperone complexes that then bind to a regulator, which then goes inside the cell and actually causes different expressions of genes. So it's kind of hard to imagine, but these steroid molecules are so well received by the body that the body actually has essentially accessory proteins that bind to them and help them perform their effects, which is really, when you think about it, it's pretty amazing. So they actually bind to intracellular receptors, they modify the inflammatory gene responses, and they suppress leukocyte proliferation and function, which is the white blood cells. And they typically stabilize cellular and lysosomal membranes to decrease the expression of inflammation. And it's this decrease in inflammation that causes the pain relief that they generate. So a lot of times people come in like, oh man, my shoulder really hurts. You give them a injection of, triamcinolone in their joint. They feel better the next day. Why is that? Well, all the inflammatory chemicals that are produced in that joint have now been essentially suppressed. And that's suppressed at the gene level, just to give you how effective that is. It's not like something's blocking them. They're actually not even being transcribed. It's as if they didn't even exist. So that's why glucocorticoids are very effective. And you can see they're used all the time. Here's just a simple shoulder injection here. The good news about glucocorticoids, they're pretty fast. So if you use glucocorticoids mixed with some local, you'll get a very fast relief. And usually people, if it's done right and you hit the right area, people will leave your office feeling better immediately, which is so cool, right? And people love that, right? So they come in, they're hurting, they go to leave, they feel great, that's exactly what you want to generate. And they obviously reduce pain and they reduce inflammation, which reduces swelling, can be very important. It also has a pretty long effect. So one of the cool things about glucocorticoids is that it has, can last for weeks to months. And obviously, as you saw through its mechanism of action, it directly changes the way the tissues actually function. It changes the way their genetics are expressed. So that's probably the most powerful form of modulation that you can have, is when you change the way that the essentially cells behave by controlling what genes that they express. There are some side effects of these glucocorticoids, and so it's very important to know these. And I hate to say this, but with modern, mainstream medicine, I'm trying to think of the nice way to say this. There's so many people that are running around. They're not paying attention. You have to see patients faster and faster. And it's not uncommon to run into a patient who may have had 7, 8 steroid injections within a year, which is very high. And the question then becomes like, hey, what's the goal here? Because they have some side effects. One of the most common side effects that can happen is that you can get this post-injection pain, also known as a steroid flare, that can occur. That is much lessened when you use local anesthetic, and we'll talk more about that. You can always get a risk of infection for 2 reasons. One, obviously, anytime you puncture the skin, you have the potential to introduce new bacteria, et cetera. However, you are also changing the genetics of the cell. Essentially, you're changing the way the cell expresses their genetics to decrease the amount of white blood cells that are around and to decrease the inflammatory signaling cascade. And so basically, those are 2 things that are commonly used to fight infections. So in many ways, you're actually decreasing the immune response to that tissue, which helps inflammation and pain, which is good. But you got to realize it does set people up for a higher risk of having an infection. There's also potential tissue atrophy or discoloration at the site. And so I have a couple pictures of that here. And these are so commonly seen. And I want you guys to know, also, I'm going to show you exactly how to fix these later. I see these all the time now because there's a lot of places that, for lack of a better word, they have kind of like they run patients through a mill. Like it's very common to see there's certain practices that are kind of like just kind of bulk. Like people come in, you're going to get 3 steroid injections no matter who you are. This is the way we're going to do them. Everybody gets them. If you don't get them, you're not compliant. And so, the mainstream medical system in some ways actually pushes these on people. And so you're seeing more and more of these side effects. A lot of times when people use, especially the particulate steroids or the white steroids, and they're going into soft tissue, you can get these atrophy sites. And you can see they're pretty significant here on this person, this lady here. You can see like it's a gigantic dent in her arm, essentially, where the tissue has actually atrophied in that area. Here's one where someone had an injection, likely for de Quervain's tendinosynovitis, fancy words meaning that basically here they have a tendon here on your hands called the de Quervain's tendon. It's commonly inflamed in a lot of different disorders. And so people inject it. Unfortunately, if you inject it too superficial, you can kind of get this where you get a discoloration and you get atrophy, and it doesn't look that good. And there people are very much bothered by this. Like I've run into a lot of people that just really are not happy with this. So, because they came for pain relief, they didn't think they would have a discoloration on their body forever. And the best news is that you can use some of the regenerative medical products, including PRP, PRFM, and PRF. Each of them have different advantages and disadvantages to actually repair these. And here Mary actually puts, I had a 1-inch depression as big as a $50 in my hip after a steroid injection. That is exactly what I'm talking about. And so the thing is that what likely occurred there is that when people put in, especially high concentration particulate steroids, many times when they first go in, depending on the skill of the person, they may inject a joint, but they may inject retrograde coming out, and they'll drag that steroid all the way back to the superficial layers of the skin. And that's how you get that big depression. Because once you get a lot of steroid concentration in the fat in the dermis, what can occur is that you can actually lose that fat, cause it to atrophy, and you get this kind of like dent, as you can see here. And then many times it's discolored, as you can see there as well. The good news is, at the end of today, I'm going to tell you exactly how you can fix it. And whether you want to fix it on your own or have somebody else fix it, I guess it's on your hip. That's going to be pretty hard to do injection on your own, but you'll at least know how to do it. So, and it's what's also great is that having that as a skill set, you'll be able to. There are so many people running around that have these, and they don't know what to do, because a lot of times, physicians are always like, "Hey, I don't really know." Like, "Oh, it's a side effect. Sorry, good luck." Which is sad, because we have the ability to regrow tissue with all of our technology now. The other thing that can happen is you can get systemic absorption, especially with repeated injections. And this is where you can get people, and I've even seen patients that have had Cushing syndrome, not because they have a problem with their adrenal glands, but because they've received something like 14 to 22 steroid injections in a year. And I know it may sound maybe abnormal, but I will tell you, I saw this all the time, especially when I had my large pain practice, because we get so many referrals from other doctors that were trying to treat pain, and they get to a point where it's kind of like, "Hey, I really don't know what to do with this guy." And we would see them, and it was, people would have gone through a ton of steroid injections, and they have systemic side effects now that are causing things like high blood pressure. They have elevated blood glucose. And, sadly, the mainstream medical system, many times, because the reimbursements are so low and they're getting lower, not even just because of cuts, but just because of inflation, there's less and less people who are focused on actually solving the problem, as opposed to just running people through the mill because they have to survive. And hey, sad but true, that's where we are. So the more that we can understand that, the more we can make a difference. So what are some benefits of using local anesthetic with corticosteroids? Well, there's quite a few. Number one, if you mix the corticosteroids with local anesthetics, what happens, you get immediate pain relief, which is really awesome. That's what you actually want, right? So you want people to hurt, they come into your clinic. You want to be able to deliver a service that they can leave your clinic feeling better, because that's like why they're coming, right? And so by using the local anesthetics, you can immediately do that. By mixing local anesthetics into the corticosteroids, you also get a diagnostic ability that is extremely useful. One of the most important things you can ever do in pain management, and you'll hear this a lot, but I don't think it's executed that well, is basically the reason why we do any kind of procedure in pain management is usually twofold. One is therapeutic, meaning our goal is to treat the pain. And then two is diagnostic, because many times in pain management, it's very unclear as to why something is happening. So for example, someone could have pain, in their hip. Well, it could be the actual, hip joint itself, as traditionally described. It could be the sacroiliac joint. It could be, it could also be, piriformis syndrome. It could also be a tendon. There's so many other things it could be. It could even be muscular or, soft tissue related, right? It could even be an iliopsoas combination. Like there's so many things it could be. So by mixing in some local anesthetic, you'll determine where that injectate spreads. If you can keep it in a close area, then it becomes diagnostic in nature. And so you can say, hey, if I give you this injection and all the pain goes away, then we know that was the cause of the pain. Obviously, having local anesthetic increases the tolerability of the injection. If you inject someone with just pure corticosteroid, most of the time, you will get some immediate pain relief, like a small amount. But it's nothing compared to the pain relief you get if you mix it with local anesthetics. The local anesthetics just immediately take care of that. And they also stop the flash, right? So the post-injection pain, also known as steroid flare, if you put some local anesthetics in there, it stops that from happening for the most part. It can still happen after the local anesthetics wear away, but in general, that doesn't happen because it usually happens right away. The other thing that local anesthetics do that's very useful is they cause significant vasodilation. One of the things that we see all the time that's really, really cool is that the more that we dilate someone's vasculature in an area of injury, the more likely they are to heal. And that goes for everything from hair, right? So alopecia, hair loss, right? Most of the treatments that we design for those typically affect the dilation or the amount of blood flow to the scalp to increase hair growth, all the way to joints. So for example, the knee. Many times, not only is the actual knee likely to have, arthritis in some cases, but when someone has a significant degree of arthritis, many times the tissues surrounding that joint are also not doing well. So the tendons and ligaments, et cetera, many times also have some benefit by having the local anesthetic cause a vasodilation to allow them to heal as well. And then finally, you can see that it has significant increased patient satisfaction. Here on this picture, these are just two different examples. A VAS score is called the visual analog scale. It's probably the thing you may have seen before where it has these faces like, how do you feel today? And there's like one where someone's crying and one's that someone happy. And they have a scale of like 1 to 5 or 1 to 10, depending on which one they're using. Basically, you can see here that with the local anesthetic, it was significantly higher at 5.4 versus 2.7 by itself. So it definitely is worth it to mix it. And I would always recommend mixing them as well. Number one, it gives you more of an injectate. So if you're doing larger joints, it's kind of nice to have more injectate to spread around. But also, to me, the most powerful thing that local anesthetics do with corticosteroids is they actually cause a diagnostic event to occur. So if someone has pain and you want to say, well, you have shoulder pain, could it be your rotator cuff? Could it be the glenohumeral joint itself? Could it be the acromoclavicular joint, which is like where the clavicle connects to the scapula right here? Which one is it? Because many times it's not 100% clear, or sometimes you'll maybe even get an MRI and all three areas have problems. Well, which one is the most significant? Well, by doing these injections with a little bit of local, you now have the ability to diagnose and say, hey, we did that injection, 10 out of 10 pain relief immediately happened after we got into the joint. We know that whatever the pain generator is, it's inside the joint. But there are, of course, downsides to using local anesthetics. Like everything, there's positive and negative, right? So number one, the biggest fear of losing local anesthetics is that there is some documented cases that local anesthetics can be cytotoxic, particularly bupivacaine, more than lidocaine. And we don't exactly know why they're cytotoxic, but we do know this occurs. And so one of the things that can happen, like the worst of all scenarios, you can get a tendon rupture. And these usually happen with multiple injections. It's very uncommon for you to give one injection of local anesthetic and corticosteroid and someone gets a tendon rupture. I've never seen that. I've never seen anybody else have that. Theoretically, I suppose it's possible, but most likely these are people that are getting repeated injections over and over and over, and that's what causes the tendon to rupture. So just realize that, especially when you're using bupivacaine, which is typically one that you might use for a lot of different reasons, but bupivacaine lasts a long time compared to lidocaine. It's also the pH of it is higher, which is kind of nice. So it kind of balances out versus lidocaine is more acidic. So the pH is actually lower for that. And then finally, you can always have allergic reactions to local anesthetics. Pretty rare, but it can definitely happen. And then, of course, if you inject, you mix a lot of local with your steroid and you inject into a wide area, what happens is the local anesthetics can spread very far. And so you can sometimes misdiagnose things. So, for example, you might inject someone's joint, and if you're not inside the capsule when you inject, well, that local anesthetic and steroid will spread all over the shoulder in such a case, right? And then it becomes hard to know, like, well, was it the actual joint? Was it the acromoclavicular joint? Was it the tendons of the rotator cuff that were hurting? Because we got pain relief, we don't know exactly why, And so many times, if you use too much local, it can kind of cloud your ability to tell, hey, what's the actual problem here, And now we're going to talk about glucocorticoids versus regenerative medicine products. And this is where it gets a little bit more exciting. So there's a really cool study here by Dohan, and it's called Classification of Platelet Concentrates. And those are PRP or platelet-rich plasma, PRFM, which is platelet-rich fibrin matrix, and PRF, which is platelet-rich fibrin. And so this is just here. This is in Muscles, Ligaments, and Tendons Journal. And so basically, this is typically we consider like a sports medicine journal, but it's a great thing. If you ever want to read this, it's a great kind of overview of the different products that can be generated. So just real quick review. Remember of corticosteroids. Remember the corticosteroids have this weird kind of effect where they actually go into the cell. They bind to these special proteins that essentially help them modify the way our genetics is regulated to decrease the amount of inflammatory response. And they treat joint pain. They're great for autoimmune diseases, of course. And the best part is they're rapid, very fast, right? So that's the good news about them. The regenerative products that we traditionally use are PRP, which is platelet-rich plasma, PRFM, which is platelet-rich fibrin matrix, which is basically just PRP with a fibrin matrix, which causes it to have a sustained release. and we'll talk more about that. And you have PRF, which is basically a fibrin network with everything PRP has in it, everything PRFM has in it with it, and also some leukocytes. And it makes this kind of clot-looking thing that you can cut up and use for membranes. You can mix with all sorts of different things, and we'll show you a little more about that too. So one of the things to kind of consider is PRP versus corticosteroids. Traditional mainstream medicine pushes corticosteroids as they push many, many drugs, like very heavily, right? And it's kind of been to the point where, now essentially, if you have insurance, insurance may not cover PRP injection, despite the fact there's really good literature behind it, but they will cover corticosteroids. And so you see a lot of patients who are getting these repeated corticosteroid injections, questionably. You look at long-term effect and it's like, well, what are we really doing here? Because they're only lasting a short period of time. And while they do relieve pain, is it right? And what's really interesting is while mainstream medicine has actually kind of shied away from a lot of the regenerative medical products, dentistry never did. And dentistry has been using PRP, PRFM, and PRF all the time. It's really interesting because a lot of times when you delve into the literature, you're going to see a lot of dental literature and oral surgery literature about this. Which is amazing because there's so many people. One of the side effects of doing anesthesia, right, is you look into so many people's mouth and you're like, oh, really? You have no teeth? The teeth is like hanging by a string, like, oh, what a mess, right? A lot of those things that would be traditionally considered endodontic treatment are actually that endodontists are now using a lot of PRP, PRFM, and PRF, which is really cool. And you can see like oral surgeons use it all the time, and they use that plus some other cool new regenerative medicine products that we're not going to talk about today. We can talk about in the future if you guys want. Here's a beautiful graph of the effect of PRP versus surgery versus steroids. And so some of the side effects of glucocorticoids is that in 5 to 10% of people, they'll get that tissue atrophy we talked about that has the atrophy of the tissue and many times a discoloration associated with it. And that's pretty significant. I mean, imagine if 10% of your patients got alarming depression that looks, alarming depression in their skin along with a miscoloration. It's really not, I'm not going to say that's the best type of medicine there. Versus PRP, you do have a potential for an inflammatory response in 2 to 8% of patients. That being said, it's very low. I typically would say it's closer to 2%. In all my time of treating people with PRP, PRFM, and other regenerative medical products, I have seen an inflammatory response once, and it wasn't clear that it was actually related to the actual products. Many times, the inflammatory responses are actually related to the anticoagulants that are used, particularly citrate. And if you guys remember citrate, right? Because you probably, anytime you infuse blood, you have the side effects of sodium citrate hanging around. And so there's, it has its own issues, and we'll talk more about its effects in healing, et cetera. But what's really cool about this graph is on the y-axis here, you have swelling and pain. So obviously, as you go higher, there's more swelling and pain. And you can see that basically starting with steroids, which is the most common, you immediately have a very powerful effect of steroids that causes the swelling and pain to go down. But roughly at about, say 2.5 months, all that comes back, if not more. And so that's what you see here in the steroids, is that questionably long-term, are the steroids that effective if you're looking at the big picture, the long-term picture? And what people are starting to come to realize is that probably not. Now, there's reasons to use steroids 100%, especially for acute injuries. And if it ever came, you have to kind of balance this with what's going on. So if Johnny has pain and the pain is like 10 out of 10 and he can't do his job, and the only thing that he can do is either take oxycodone or have a steroid injection, well, which is the lesser of the two evils, right? So they're, realize that doesn't mean that steroids are completely bad for everybody. And there may be some situations where it would be wise to use steroids to control someone's pain. But take a look at what PRP does. It's here in the red line. Basically, the swelling and pain, pretty strong effect of it decreasing significantly. And here at 1.5 months, it doesn't rebound. It actually decreases swelling and pain and actually holds it. So even though it's maybe not as fast of an onset as steroids, you can see that it definitely has a better long-term profile. And if you compare both of those to surgery, which is, let's just say heavily pushed in our medical system, So if you look at the surgery, I mean, obviously the swelling and pain actually increases more than all of them, initially, obviously with the surgery. And then after over 3 months, it goes down. And then, questionably, a lot of the long-term data for some of these surgeries, if we really look into it, like knee replacement, these things, they're not as favorable as we once thought. Just to kind of summarize that. And that's why I think what my goal is to empower you guys to have regenerative medicine as a skill set in your back pocket or an arrow in your quiver, however you want to call it. Because there's so many things that you can do to help people that, sadly are not encouraged by the mainstream medical system. Here's a beautiful graph here talking about mainstream medicine. And so, one of the things that mainstream medicine does, it really promotes the use of glucocorticoids, because if you're a patient who's, maybe you don't have a lot of extra money and you have insurance through your employer and, hey, I need to get treated. And to be quite honest, I can't really pay for it. I just, whatever the insurance pays for is what I can get. Well, glucocorticoids are lower cost. They're typically covered by insurance. PRP many times is out of pocket, and it can cost anywhere between $500 to $2,000 per injection. And it's up to you guys how much you want to charge, but you'll see that the actual cost to generate PRP is very cheap, and I'll show you how to do that later. But it really doesn't cost you that much to do that. But here is actually a beautiful data from a study here about plantar fasciitis. And if you know anyone who's had plantar fasciitis, it's one of the most annoying kind of pains you can have, because for most people, they're on their feet all day, or at least they're walking a big chunk of the day. And so having plantar fasciitis is very painful, and what most people say is debilitating. And you can see here with the PRP and steroid, they have almost the exact same effect of actually decreasing those pain scores, but yet the steroids have that rebound effect to, almost, not quite the same level initially, but to a decent level after their use. Versus PRP kind of remains, that kind of effect remains there present, where it's actually healed the tissues. So the important thing to realize is that while initially glucocorticoids may be cheaper or covered with insurance, and I'm not saying that you maybe shouldn't use those initially, because sometimes when someone's in 10 out of 10 pain, you can't even think straight when you're in 10 out of 10 pain. If you can at least turn that off for them, okay, cool, let's use some glucocorticoids. But hey, long term, let's actually do something to fix this, because we see this common rebounding effect with steroids, where someone has pain, is treated temporarily, and then they rebounds into, if not the same pain, a very similar pain. And this is a common cycle you see, especially in pain management clinics, right? You see people come in for a procedure, they get the procedure, they're doing better for a little while. And then what happens, they need another injection, but this time the injection doesn't last as long. And they get a third injection, and this time the injection worked, but it lasts even shorter than the last time. And they get this kind of cycle where it's like, I don't understand what's going on. I'm getting these injections, they work shorter and shorter, but the pain keeps rebounding back further and further. And you kind of get in this cycle of, injection after injection after injection. And that's how you can easily get, patients that have had, I would see patients. I remember one patient I saw had 26 knee injections of steroid in 1 year. And that was, to be fair, that was a very high, I was like out of the ballpark high, but I just couldn't believe it happened. And when I went through the notes, it's just like the guy went to one provider, then to the other provider. Nobody read the other provider's notes. They just saw him as if they had just seen him the first time. And everybody recommended doing the same thing, which the insurance covered. And so they just kind of get the same thing over and over. The patient didn't know any different. He's like, hey, I need another knee injection. It's only lasting a week now. Let's get another, And so we had to treat a lot of things going on there. But we ended up getting better. So now that you know the advantages and disadvantages of glucocorticoids, what do you really need to do this? And I wanted to show you a little snapshot from my Amazon account here. This is a centrifuge that you can buy on Amazon. As you can see here, I purchased it two times already. The last time was in February 9th, 2021. And I've used this now we have it in 2 different clinics now here in Dallas. But this is just a cheapo, centrifuge. By cheapo, I mean, it's a good quality centrifuge, but it's not a brand name. It's not, something that has special kits that come with it. It basically is just a simple centrifuge. But most importantly, it has 2 things. 1, you can control the time that it runs. And 2, you can control the rotations per minute. And that's all you need in a centrifuge to make most of these regenerative medical products. And the thing is to show you is that basically for $300, you can have a centrifuge. But to be real, in order to basically do your own injection, the actual cost of it, you need 1 centrifuge, which is $300. You can use it over and over. Obviously, you need some blood tubes. And depending on what you're going to make, some of the blood tubes have anticoagulants, some of them don't. And we'll talk more about that. But basically, for about, I think what it boils down to is for about $6 to $8, you can generate almost any regenerative medical product derived from blood in your office or in your clinic. And so it's pretty easy to do. And so I just wanted to show you the power that you guys have, because it's not hard to learn how to do this stuff. And, obviously there's a huge demand out there. People are always hurting. That's one thing great about pain management, is there's a never ending demand of patients. And the thing is that you have the ability to heal them and help them. So what products can you actually make with a centrifuge? These are all the products that you can make with a centrifuge. You got PRP, PRFM, PRF, which we already talked about. And you have some other things that we're not going to talk about today, but realize they're out there, because I want to show you just how many cool things you can make. So you have LPRP and APRP, which, for lack of a better word, these are PRPs that stimulate an inflammatory response similar to prolotherapy. So, prolotherapy, the idea behind prolotherapy is like, hey, if there's an area of the body that is injured, what I'm going to do is I'm going to go in there and I'm going to cause inflammation, because I know that inflammation will cause the body to mount an immune response, and that immune response will heal the area. This is commonly done. It's done in aesthetics all the time, right? I mean, if you guys ever use old therapy, right? What are you guys doing with ultrasound, right? You use ultrasound to cause an injury. Same thing with PRP, microneedling, et cetera. You cause an injury for the immune response to come in and basically heal that area, regenerate new tissue. The same thing occurs in orthopedics. Same thing occurs in all the different areas of the body. You also have concentrated growth factors, which you can derive, which are very useful. You have PPP, which is platelet fluoroplasma. That's very useful for lubrication, et cetera, and still maintains some of the great proteins that are necessary. And then you have autologous serum, which is great for hydration, and sometimes used in ocular cases. So a lot of times they'll use that for ocular wetting, et cetera, if necessary. So you can derive so much stuff just from a $300 centrifuge and the ability to draw someone's blood. And that's why I wanted to make sure you guys know this, because to me, this is like one of the coolest things that you can do to help people. And I think that what you'll find is that each of these products, they're like their own tool, in the same way that a sculptor might use different tools to achieve a different effect on their sculpture. You can use each of these products to achieve a different effect on your ability to heal tissue. Each of them have their advantages and disadvantages. Each of them are useful in different situations, but they're all useful depending on what's going on. However, we'll talk about these three because these are the top three that you'll probably use, these a little bit less often. So real quick, let's talk about platelet physiology. As you probably noticed, all these things have pretty much all the top three have platelet in them. And so what is it about platelets that make it so useful to heal people? Platelets release these essential growth factors when they're activated. So when platelets when you have like an injury, so you cut yourself and platelets start to stick to that injury, they release these growth factors that heavily promote tissue repair, angiogenesis, which is basically making new blood vessels, and collagen production. And they do that through these growth factors here. So everything from, without getting too much into detail, PDGF, VGGF, FGF, EGF, you name the acronym, it's out there, but realize that these little growth factors are the things that actually make the healing work. And then just to give you an idea, here's a picture of a platelet, and you can see all the things that are in a platelet. Noticed here the alpha granules, and you also have dense granules here. The alpha granules are kind of what we're after, because the alpha granules have all of these in here. And so the alpha granules in red here, these are all the growth factors that are inside a platelet. You can see how many of them there are, significantly large amounts. The dense granules are the granules that have the calcium in them, the epinephrine and histamine. These are typically used in wound healing. And they're part of, like, when you trigger a coagulation cascade, the dense granules actually kind of promote that coagulation cascade from to continue to scale and keep going on. The alpha granules are the ones that release the healing factors. So our goal in general is to get these growth factors here, and basically using platelets, using the patient's own blood, take those platelets out, and then stimulate those platelets to do a number of things so we can get those growth factors, put them on the area that's damaged, and have that area healed, which is really cool. Here's just some more exactly what they do. I don't think it's important to memorize all of them. The big picture here is that Number one, realize that many times the names of these growth factors, they were, many times they were discovered and it thought they did only one thing. And then later they found out, oh, it does like 12 things. And so, for example, they can, like, here's one vascular endothelial growth factor. You think, oh, well, it's for the vascular endothelial cells, right? Well, also it does migration and mitosis of endothelial cells. It increases permeability of vessels, stimulates chemotaxis of macrophages, et cetera. So realize that many times those growth factors can do multiple things. I wouldn't waste your time memorizing any of these. Just realize these are the things that are actually doing the work for us. One of the coolest things that can happen during a platelet coagulation is that it makes these little fibrin matrices. And what's really cool is the fibrin matrices are designed to kind of stop the bleeding. This is what eventually becomes like a scab, right? And it has this kind of effect where once it gets triggered, it causes the release of these dense granules, which then cause it to continue. So it's almost like a match starting a campfire. Like it takes a little bit of initiation, and then once it goes, it's self-perpetuating, and so it causes this huge effect. And what's really interesting is that having this scaffold from fibrin matrix scaffold, it actually causes the effect of the healing to be prolonged, but it also makes the healing more effective because you have cells like this here's macrophage floating around. And if it finds fibrin, it's able to actually connect to it. And it actually was able to what they call chemotaxis, which is basically using the cell can actually travel along these fibrin matrices to get to the areas that are damaged. It's really, really cool. So by having that, scaffold the fibrin matrix, it really allows for migration of fibroblasts, keratinocytes, and endothelial cells into wounds so they can start to heal. And as you can see here, this natural scaffold does prolong the release of growth factor over time. We'll talk a little bit more about that as well. So these are the three ones we're going to talk about: PRP, PRFM, and PRF. I know there's a lot of acronyms to remember, but it's all platelet rich. And then if it has an F, it's fibrin. And basically, so you have PRP, platelet rich plasma; PRFM, platelet rich fibrin matrix; and PRF, which is platelet rich fibrin. And so we'll show each of these. So what's great about all of these is they're derived from the patient's own blood. So what's really cool is that because they're derived from the patient's own blood, it skips a lot of the FDA regulation. And so, everybody has their own opinion about these things, but the FDA, many times, while it may do a good job on regulating some things, it would be not unfair to say that sometimes when new things are found, in order for those new treatments to be brought out to the market, the amount of steps that is required to basically take something that may heal someone and actually get it to the marketplace requires several $1 million in studies. And so because there's this huge barrier to entry, that's why we don't have so many drugs that are available, because essentially in order to play in this game, you probably need to have somewhere between $6 to $10 million for your initial study to get through the FDA. So even if you found the cure for cancer tomorrow, the reality is that you're going to need a huge investment of time, energy, and money to actually even prove that it is safe to just get it to the marketplace, all through the FDA. But because these are used from the patient's own body, we're able to kind of skip all that, which is really cool. And because of that, we don't have the same side effects. For example, if you're using, placental tissue or something like this, you can always have reactions like graft versus host versus graft. Well, because they're from the patient's own blood, you don't have any of those reactions, which is great. There's been several studies to study all of these PRP, PRFM, and PRF. And what they found was that pretty much negligible allergic reactions with all of these products, which is great because obviously it comes from the patient's own blood. So it'd be unlikely that they would react to them. Makes sense, right? So let's talk about PRP, kind of the most famous of all of them because it's been around the longest. And what's great about PRP is that it's a liquid. So it's very useful to inject into things because it is a liquid. And so when you spin down some blood, what you find is that you have a separation here. So I take some blood, I put it into a little test tube here that has some anticoagulant. I put it in a centrifuge, spins around. I'm going to collect the heavier items at the bottom, the lighter items at the top in terms of density. And so what I'm going to get is somewhere in between. I have this platelet-rich plasma right here, and then I got poor plasma on top. Each of these are very useful in their own right, but the PRP is this kind of middle layer here, and that contains very high numbers of platelets which are typically found in the blood. It's really easy to produce this. You simply draw some blood, you separate the platelets, you basically extract them using a needle, and then you can inject them wherever you need to. This picture I really like because it shows the complexity of the healing process that is involved and how amazing that these little platelets we have floating in our blood can eventually become that thing on the screen. Where you see here, it's releasing granules, it's talking to different types of cells, it's activating things just by its presence there. Not to get too like detailed because you can go down this rabbit hole for probably like a couple of days. Realize the platelets, obviously they do the clotting and tissue repair. They have the growth factors, which stimulate the cell growth and healing. And they have cytokines, which are basically intracellular or cellular messages, right? So the cytokines tell different cells like kind of what to do. And it's the growth factors and cytokines that we want to harvest and use repeatedly in order to heal different areas. So here's a real picture of PRP. And you can see here, when you spin the blood down, you get this kind of yellow area at the top. That's PPP or triple P, poor plasma. And then you have the platelet-rich plasma that's right here between that and the red blood cells. A lot of people, when they make PRP, they're not familiar with how to centrifuge it. There's been a lot of studies on this, and I recommend that you do a double spin in order to create a high density PRP. So basically, the important thing to realize is that, each centrifuge, depending on which one you get, and depending on the size of the centrifuge, so the wider the centrifuge is, the bigger the diameter of the centrifuge, the settings will be different. So, if you have a very small centrifuge, the settings will be different than you have a centrifuge really big, right? Because the diameter directly affects the amount of force that's on the actual test tubes as they spin. Without getting too much into math and physics and stuff, just realize that different centrifuges have different settings because of their size. And so typically what we try to do is we try to get a kind of a low gravitational pull around 300 Gs, 300 grams of force for about 10 to 15 minutes. Then a second spin at a little faster rate, which give you a higher G force or gravitational force, right? And so somewhere around 700 grams for another 10 to 15 minutes. And this concentrates the PRP into very high concentration, which the higher the concentration, the more effective it is. And then we have PRFM, which is basically we take the PRP and then we add a little bit of calcium chloride to it. And depending on what you're going for, there's different amounts. But it causes this fibrin matrix to occur. And here's a beautiful picture of an electron scanning microscope actually looking at a fibrin matrix. And you can see there's little cells that are actually walking on the fibrin matrix. Isn't that incredible? So it's so cool to see that because, you might imagine if you're a white blood cell just kind of floating around, three-dimensional space, it might be hard for you to get to certain areas, because you don't have like a flagella, you don't have like a tail to help you swim. You're just kind of floating around. Once you have a scaffold, well, now you can walk on that scaffold and get to where you want to go. Once again, it shows the complexity of the human body and how amazing it is that, we have cells that can walk on scaffolding to heal us, Here's the difference between PRP and PRFM. And the more you understand this, you realize that neither of them are better or worse than the other, but they're used for different purposes. This graph here on the left shows the growth factor release for PRP, which is very quick, huge initial onset, and then it goes away very quickly. Compare that or contrast that to PRFM, where you have an onset that's perhaps a little slower, not nearly as high in the peak, but it lasts way, way longer. And so the PRFM is typically used to basically have a longer term healing than PRP. So for example, if you're using a treatment for short-term healing, PRP is going to be your choice. If you're using a treatment for long-term healing, like maybe someone has osteoarthritis for 3 years, the PRP will have a short-term effect, but will go away. You might consider using PRFM for the longer term healing versus, let's say you're doing microneedling to make someone younger, right? So you're going to basically numb their face. You're going to have a little device that has needles that go in and out. And you're basically going to make channels in the skin. You want to have an immediate effect on that because you don't want people to have, you want people to put a product on immediately, have an effect, and then have it be able to be washed off relatively soon. So that would be the PRP that you'd use for microneedling. You would not necessarily use PRFM for microneedling because you'd have to leave that product on much longer to get the effect. But if you were, for example, treating a tendon, like, someone's tennis elbow, a lateral epicondylitis, fancy word, for that, you'd probably use the PRFM because you prefer to put it right on that tendon and let it sit there and then release those healing factors over a long period of time to get your best healing. Pretty easy to make. You basically put them into the centrifuge here, and then you're going to take them out. And then with PRFM, you're going to add a little bit of calcium chloride, and that calcium chloride is going to basically begin the clotting cascade. And depending on how much you add will depend on how thick it gets. And so it makes it into kind of a gel-like substance. And so once you have PRFM, what's great about it is kind of moldable depending on how much calcium chloride you use, and also your spin ratios. And it's very useful. And so, for example, Scalafini here in 2015 showed that PRFM has a 2-fold increase in growth factor concentration over a 10-day period compared to PRP. So most people believe that PRFM is actually more powerful than PRP. And I would tell you it's probably true. However, PRP is more powerful in the short term. So if you only have a short-term ability to put something on someone's skin because it has to be washed off or whatever, PRP is going to be your choice. They also have seen some research here showing that PRFM is actually more cost-effective, about 15 to 20% more cost-effective because it has those prolonged effects compared to PRP. That being said, honestly, anything that you do, basically, you'll find that it's going to be better for you to use any of these products than using traditional mainstream medical products, because in the long run, they'll all save more money than that. So for hair loss, we definitely want to go ahead and have a long-term effect. So what we traditionally, some people will use PRP as what's classically described, and there's nothing wrong with that. But if you're going to be putting, if you can put in a firm gel-like substance into the scalp, like PRFM, you're going to have most likely better results. So for me, what I use a thing, it's basically PRFM. We actually make our PRFM, it's a little bit more, less ability to clot. And so we actually put that into our scalp injections because it lasts longer. And as you can see, it has a better effect long-term from the studies. And then here, once again, you have another one, Scalafamily and Sampson, 2008, showed that the sustained release of growth factors due to that matrix can actually have PRFM last for 6 months or more, whereas PRP effects are between 1 and 3. Anyway, going back to PRFM, you can see here, basically, it's another zoom in the electron microscope. It's incredible to see that your body does this all the time. I mean, look at that, this incredible design. Has the basically advantage of the extended release of growth factors, has the fibrin matrix, which is protective, allows migration of cells. The downside to the PRFM is that because it's more of a kind of like a gel substance, sometimes it can get clot, like you can clot in small gauge needles. And also, if you don't inject it properly or mold it properly, it may not actually go to the right area. So you have to really put the PRFM directly on the area you want to heal. Versus because PRP is a liquid, it can travel further. So if you get kind of close, it's more like a grenade. It can go, it like has a bigger area of treatment. So if you get PRP close to the area, you'll get some effect. PRFM, the effect is somewhat smaller, so you got to be directly, a little bit more precise, And then there's PRF. Nobody ever talks about PRF, but this is commonly used in dentistry, by the way. I think the reason why nobody likes it is because it looks kind of gross. But basically, if you take someone's blood, you put it into a test tube that has no anticoagulant, none, right? And then you spin it. What will happen is it will naturally cause coagulation. Like as soon as the blood hits the glass of the test tube, it immediately starts to clot. Once you start spinning it immediately, so you can't let it sit down. Like you can't just put it in a test tube and wait an hour and then spin it. Like you spin it within about 2 minutes, 30 seconds, and you get it spinning. And so once you get it spinning, you'll create this kind of thing that looks like this. It looks kind of kind of gross looking thing basically here. And what it is essentially, it's a 3-dimensional fibrin matrix that contains platelets, white blood cells, and stem cells, by the way. And it's really great for like membranes. So that's why a lot of times it's used in endodontist work, right? So if someone has maybe they had a tooth that was infected, and so we pull the tooth and now there's an infection there, the gum's not doing well. Maybe this is somebody who never took care of themselves, got heavy gingivitis. I got to heal that gum, right? And we know that, so important that, oral hygiene is directly connected to cardiac, ability as well. Many studies showing this. So it's really important to heal that as we don't have, constant infections of the blood. And so I might use something like this, the PRF, to actually make a membrane, cut it, and then put it inside the area that's damaged, and it acts like a membrane and covers it up while it releases those growth factors. So it's really cool. Here's how we actually separate these things. Pretty easy here. Basically, you have the 2-step versus the 1-step spin. I'm not going to say one is right or one is right or one is better than the other. But basically the two-step has been shown to be more effective. You start with a slow speed spin and it causes, you can see here, like you kind of get the first spin, 200 grams at 12 minutes. And remember, these are variable depending on the size of the centrifuge, right? So just because somebody says, hey, I'm doing it for 12 minutes, unless they have the exact same centrifuge you have, realize that it's different, you know? So basically you have the first spin here. Once you do the second spin, you're going to get this beautiful PRP area here, and that's what you want, right? And then, you know, here we separate the PRP versus the PPP, poor plasma. If you do the single spin, you know, obviously it's faster, but you don't get as much effect because here you have everything kind of mixed together. So a lot of times people just do one spin and use all of this as one product, which is okay. However, I would suggest that you do the second spin. You know, it doesn't take that much longer, especially on like a normal centrifuge, normal size centrifuge. This, obviously, the smaller centrifuges take longer. But like basically, it doesn't take that much longer. And that way you have some products that are highly effective and you have products that are less effective. And that way, you know, like, hey, for the areas I know that are damaged, I want to put the highly effective products on those areas, right? So hopefully that works for you. And then we do have a study, Magellan et al., showing that you have a higher yield and platelet concentration 5 to 7 times baseline by doing the double spin. So if you get a chance to do double spin, I know it takes a little longer. It's totally worth it though. And it will give you the ability to do both. And that way, you know, for example, once you have the PRP, you know, hey, this is the gold, right? And you have the PPP, this is kind of like the silver, you know, so you know which one to use for which area. A couple of parameters that you always use when you do centrifuges, right? You got the RPMs, rotations per minute, and you have the time, which is the duration of centrifuge. And so here's just some examples that, you know, are out there, you know, 300 grams of force, you know, obviously depending on the radius. And so these are just some recommendations. And you can calculate these from the centrifuge, or if you guys have the same centrifuge that I recommended from Amazon, like, you know, and you don't have to use that one. I mean, even to the fact that I think my first centrifuge I had was actually from Quest. Actually Quest, the lab, like the blood company, the blood testing company, actually gave me a centrifuge. It wasn't as cool as the one I got from Amazon, but it basically did the same thing. So, you know, sometimes if you order a lot of blood tests, these companies will actually give you the centrifuges as well, and you can use those as long as you can change the RPMs and the time. That's all you need. And then obviously this is the calcium chloride you're going to use. This is your typical Abuject syringe of calcium chloride, which you see in a crash cart. This is the one that I use, obviously for the PRFM. You can use others if you want to, but these are pretty effective. And, you know, should you ever need them for emergency, you have them as well. So kind of cool. And here's just an example of the PRFM versus the PRF. And so, for example, for PRFM, we're going to do the first spin here. We do a second spin, and we're going to get our PRFM here, which is kind of like a fibrin, you know, gel here. If I do PRF, which is that kind of yellow clot looking thing, you can see here that basically I just take the blood, put it right into a blank test tube, no anticoagulant, let it spin, get that thing spinning as fast as you can, because if you let it sit too long, it'll clot and won't work. But you let it spin while it's clots, and then you'll get this kind of yellow looking, dare I say, mucus looking thing. And this is that membrane you can cut up. You can mix it. You can use this for a lot of cool stuff. If you want to, you can cut it up and put it into different products. Some people will cut these up and mix them with dermal fillers. Some people will cut these up and put them into joints. If you have the ability, for example, if there's someone who has, for example, like a tissue atrophy from maybe a steroid injection, you can actually cut these up, and if you can inject them through a large gauge syringe, you can actually inject them into that area, and they kind of form to that area, and you can actually massage it and then have that just kind of sit there and just release growth factors all the time, which is very cool, you know. And there's a couple other things, you know, obviously you got to get the right test tubes, you know. They're not very expensive. Sometimes they're hard to find because sometimes there's shortages. Remember that most of the test tubes you use will have anticoagulants. The number one coagulant you're going to have is citrate. And as you may be aware, citrate has been shown to not be a good promoter of healing. However, the amount of citrate in most of these, when you create PRP or PRFM, it's very limited, especially in PRFM, because you actually use the calcium, which actually binds the citrate, which kind of takes it out of the mix. So just realize that like there is a theoretical risk that the anticoagulants are not that beneficial. However, what I've seen practically, really no problems, you know. And then you have the platelet concentration. You're looking for 4 to 6 times concentration over baseline. And that's for, most procedures that you're going to do. Here's just some references here that I'll use in the studies. Should you guys want to, read these, that's awesome. Should you not want to read them, I kind of went over the best parts of them anyway. But if you like to read, they're there. And that's it. So I'm so glad that we were able to cover this, and I'd love to answer any questions you have, and I'd love to talk to you guys about, for some of you guys, you've reached out and say, hey, is there anything I can do that's kind of outside of the OR, being burned out, being on call and doing these emergency cystos at midnight and 1 a.m. when, they're not really emergencies and that kind of thing. I know exactly what you mean. I've been there myself, and I can tell you, I'm sure we could all swap a lot of stories about those things. But feel free to ask any questions you have now in the chat box. And one of the things I just want to mention to you is you all have the ability to help people with these technologies immediately. As you can see, the cost to get into this is, less than $1,000, $300 for, centrifuge. You're going to need some medical supplies, butterfly kits, some test tubes, some syringes, some needles, nothing huge, some gloves, that kind of thing. And realize that, one of the most overlooked things that happens is that you can, a lot of people would say, well, I don't have a place to practice. I don't know what to do to get started. First thing I would do if I were, if you're ever interested in doing this, please realize that number one, there are, things there, if you need help or something, you need to get trained, like, let me know. I'm happy to help you. But for most of you, this, like doing a knee injection, for example, it is easier than doing intubation. Like, realize like the stuff you do every day is harder than doing these things. So for example, you could go to a chiropractor that's in your area, talk to them, and many chiropractors would love to have you in their office. And the reason why is it gives them more credibility. It gives them the ability to have treatments that, normally they'd have to refer out. And so, for example, we've worked with a lot of people, and, whether they're doing aesthetics or, orthopedics, regenerative stuff, I like chiropractors a lot because chiropractors have a pre-existing patient base for you to immediately use. They're usually they're much more business oriented than doctors. And majority of them, obviously not all of them, but majority of them are fairly reasonable to work with. And so many times the chiropractors are very happy to have you come to their office, maybe rent one of the rooms from them, sometimes for a small fee, or sometimes they'll just give it to you just so they can have this service available to their patients. And many times they have existing patient bases that need all this stuff. And so you could immediately start doing these kind of procedures if you so desired. I would recommend that you obviously adjust your malpractice insurance. You have some form of training that gives you a certificate. You definitely need to have a certificate because that's for your malpractice. And should anything go wrong, you want to prove that you've been trained somewhere, But other than that, which, is fairly easy, you can go and start helping people right away. And, for a lot of us, I know, for me, especially, like many of the members of my family, I would intervene in their medical care all the time. And I'm not trying to say like this is the best idea. So to take it with a grain of salt, but what I kept finding was stuff like my mom would have knee pain. She'd go to an orthopedic surgeon. They would prescribe her Celebrex, right? Hey, no side effects there, right? Like prescribe and like and what was they gave her Celebrex, they gave her a knee brace, and they gave her some kind of topical thing that was like $2,000 a month that charged her insurance a fortune, and she had to pay a huge copay on. And I was just like, what is going on here? Like, this is obviously not effective. And so I started treating my own family members with this. And so if you have family members that are suffering from chronic illnesses, this stuff is not hard to do. And so Renee just put like, yeah, just a Band-Aid. And then just kind of talking more about some of the questions that have come in here. Can you add lidocaine to PRP, PRFM? Yes, you can. Please realize that lidocaine is very acidic. So if you're going to add it, you need to buffer it a little bit. I don't recommend that you usually use lidocaine for PRP or PRFM. You can often, like, say, for example, you're going to do a joint injection. You might use lidocaine in the actual skin to numb the patient, and then basically go through the area that has been anesthetized into the joint, and then only put in PRP or PRFM, or sometimes what we call cytorejuve in the joint. And those things can help heal the joint. And that way you don't have to put actual lidocaine in with the actual, the growth factors. And the reason why is because if you affect the pH too much one way or the other, it will decrease the ability for it to heal. And so that's why I recommend that you, in general, if you can use PRP or PRFM, try not to mix it with local anesthetics if you can avoid it. If you're using corticosteroids, hey, our whole goal using corticosteroids is fast relief as fast as we can. Our goal is not to repeat this a lot. It's meant to like, hey, get somebody out of pain really quickly. And so for that, definitely mix it with the local anesthetic. And so Renee asked here, where do you get the training? Some of the training I recommend is that, there's obviously different places you can get it. My favorite place is going to be the American Arthritis Foundation. They have excellent training. They're usually, I think they're pretty full most of the time, but if you can get into their training, they're very effective. And I even teach for them sometimes as well. And so if that helps you, just let me know. I'm happy to help or make an introduction. But basically the training that I would recommend is regenerative orthopedic training. And the reason why we focus on, you can use this for any tissue, but the reason why we're focused on orthopedics is there's so much joint pain. And just to give you an example, we had estimated that there was going to be so much knee pain as people aged, right? So if you look at the graphs of projected knee pain in the American society, it's kind of like this curve going up like this. Well, what we found in the data recently was that knee pain is actually significantly more than we even estimated. So we're seeing that many of the people are having arthritis at higher rates than we've ever expected. And so you can do so much to help people with arthritic pains by using these derivatives of their own blood. And as you can see, your total cost very low. Your total cost per patient to do these, I mean, you're looking at maybe $8 to $10 in medical supplies, But basically, what I would recommend is that you consider making a relationship with a high-end chiropractor in your area. And the reason why is the high-end chiropractors already have existing patient bases. By the way, most of the time, it's very rare to find a chiropractor that takes insurance anymore because they pay so little to them. Most of the time, those chiropractors have cash paying patients because those are the ones that already see them. So majority of their patients are already paying cash to get better. And that's really critical because those are the people you want. You want the people that are interested in getting better, people that are willing to put their money where their mouth is and say, hey, I'm going to put my own cash in to heal. And the reason why is because that person who's actually paying for help, whether it's to the chiropractor or to you, that person is dedicated. They're not going to be the person that ignores your orders. You're going to tell them, hey, I need you to do X, Y, and Z. And they're going to do it because they're having to pay. There's always a famous saying, whoever pays attention. And it's somewhat true. If things are free, many times people devalue them. And so sometimes with insurance, you have a lot of patients that are not compliant for a lot of different reasons. But with insurance, it's because, hey, it just costs them whatever their copay is. And so, maybe it's not a big deal for them. It's $20. Okay, well, he recommended this. I don't feel like doing it today. And so you get less good outcomes when people don't follow your instructions, right? You have the ability to help so many people, and it's very close to where you already are. So if you want to do something outside the OR, outside of mainstream medicine, probably the easiest and the cheapest thing you could do is to basically go and start helping a chiropractor with some basic procedures. These would be like joint injections. Some of the things that you already know how to do in anesthesia, you can do. If you already know how to do occipital blocks, auriculotemporal blocks, you can do headache blocks, which are huge. They really help a lot of people. We had a lecture on that in the past, which was pretty cool. You can do, obviously any kind of pain management procedures, but what you'll find is that especially for the chiropractors, they'll have many patients that they're seeing over and over for chiropractic therapy. And you have the ability now, from your understanding of this, and I'm going to email you out a handout and put it into our, of course, the Panel C learning system as well, that shows you all the different products you can make and how to make them from a centrifuge. Let me just pull it up real quick for you guys so you can see it. And so that way you guys can make any product you want to. Okay. So hopefully you can see this. This is the regenerative products from blood. These are all the products I mentioned that you can derive. Here's how to derive them and some kind of, common uses. Especially we use these a lot in aesthetic medicine. So that's why it says aesthetics there. But basically you can use them obviously in anything. And do well with it. Is there a difference between these products and stem cells? 100%. So I practice regenerative medicine all the time. I highly recommend that everybody learn it because to me, it is the future of medicine. I believe that medicine is undergoing a massive change. And I think anybody who's in the field can see this. The reality is that Medicare is bankrupt in 2025. They will essentially hit bankruptcy. They might be able to delay it 1 or 2 years if they're lucky, but in the end, it's coming. It's been coming for a long time. Everybody's kind of known it. And so when that happens, you will see healthcare change rapidly. And you can already see that healthcare individuals are, people working in healthcare are getting paid so little compared to their counterparts in, for example, home services. Take, for example, a coronary artery bypass graft, right? A CABG. So in order to do a CABG, as you guys know, you got to cut someone's sternum open. You basically got to stop their heart. You got to, harvest some veins. You got to put the veins in. It's a huge, huge operation, very detailed. Got to go on bypass, got to come off bypass. So much work, right? The professional fee to the cardiothoracic surgeon who has spent 10 years in their training basically is around $1,000. So that's why it's harder and harder to find these guys, because it doesn't make sense, right? You could make more money as a plumber or working in construction, perhaps, some kind of home services. Even the pool guy can make more money than sometimes a cardiovascular surgeon. And so many times, what's happening is that these medical services, like some of the surgical services, like for example, cardiovascular surgery and neurosurgery, the professional fees are not enough to even support the profession. They're a joke. That they really are. If you look at like a laminectomy, right? So you're going to cut someone's back open, you're going to cut out a piece of the bone of their spine, and then you're going to close all that up. Like that, I think pays around, I think it was $1,500. And just considering the liability, and then you got to see that person at no charge the next 90 days because there's a global period on it. Just doesn't make sense. So what's happening is that these specialties are basically being supported by the hospital, because the hospital is able to bill for all of their products and their OR time and those kind of things. That's the only thing that is actually supporting this. And so when that gets cut next, what you're going to find is that it just doesn't make sense to stay in mainstream medicine. And you can already see this what's happening, because if for all of us here on the call, I mean, how many of you have had pay increases of 30% in the last 3 years? Because if you haven't, then you haven't been keeping up with inflation. Because if you're getting paid the same today as you were 3 years ago, you will see very clearly when you go to the grocery store, whenever you buy your malpractice insurance, whenever you do anything, the cost of everything have gone up, hasn't it? Is that not true? So everything's more expensive, but yet your pay hasn't increased. Well, the reason why is that the reimbursements have actually been consistently cut over the last 30 years. They're continuing to be cut despite the fact that everything costs more. So as your dollars devalue, what's going to happen is if you're in mainstream medicine, the only place that it's getting to a place, and there's a lot of different people say why this is happening. I'm not here to talk about politics, but just for people that are working in the space, you need to understand they are moving more toward a socialized medicine structure. And if you look at socialized medicine structures in most other countries, for example, Great Britain and Canada, you will see that they're not so great. And, some people may disagree with that. I honor your opinion, but I ask you to please talk to somebody who lives in those countries, because they will tell you they're not so great. I remember when I was actually in medical school, I worked for a physician in Florida. They make us do this thing called an externship, where you have to basically go work in a clinic. I think it's for a month and a half or something. And so I got sent to this clinic, and it was a guy who was actually French Canadian who had moved down to Florida. And basically, his entire practice was all Canadians. Despite the fact that they had, government paid healthcare, they actually flew from Canada down to Florida to actually see this doctor and get treatment and surgeries and these things, because they could not get them in a reasonable time frame in Canada. And that was at the beginning of their socialization. Now it's actually gotten worse. So, and you can see in the UK, for example, the national health system has actually gone bankrupt almost, I think it was several years ago, actually went bankrupt, and they still have issues with its funding. They're always cutting, et cetera. So realize that mainstream medicine is changing, whether you're for that or against that. I don't want you guys to ever get into a situation where you are dependent on the system, because the system is designed to use you and abuse you. If you ever worked in a hospital, you know how it is. More cases, more work, faster turnovers. Oh, if you guys are not done yet, it's anesthesia delay. Oh, you need to go move faster in the OR. Is this really about patient outcomes? Or is this about surviving because our pay has been cut so many times, right? And this is what you're seeing from the hospitals, because the hospitals are also doing that. So true. And then, if you look at, if you ever heard Dana Standard's story about her lawsuit, she got sued for things that most people would be considered normal, and even was told she was responsible for knowing the credentials of everyone in the OR, including the nurse that was in PACU. I mean, when does your responsibility end for your what is it, $12 a unit from Medicaid? Like, really? So for your less than $75 charge for a short case, you're responsible for knowing everyone's credentials, taking care of the patient, documenting to a T, doing all this kind of stuff. This is getting to be too much, right? And so that's why I recommend to everybody to at least, put a foot out, put a hand out, get a side gig, like do something kind of just for fun or whatever. Go help some people. You take this lecture, learn how to do some joint injections. They're not hard. If you need help, email help@painless.e. We'll connect you, whatever you need. But grab some other skill sets that you can do that will give you some cash coming in outside of mainstream medicine, because we can't trust the government and mainstream medicine to really do what's in the interest of the patient, and most importantly, the interest of the provider. And I say most important, the interest of the provider, because if there's no providers, you're not going to have any care. And that's the thing, is that as they continue to crush and basically, harder work, more effort, more documentation, more pressure, more, what's going to happen is there's just going to be to a point that you just don't, it just doesn't make sense anymore. And that's what you're seeing. Like, I saw there was an excellent cardiologist here in my area of Texas. Guy was really great. He was very intelligent guy. I sent several patients to him, and he was so nice. He would meet with patients. He would review their echo with them on the screens to actually see their echo in real time. And then he'd modify their medications, and then he'd be like, many times people have heart attack first. He'd modify their medications, optimize them, tell them you get on this diet, this supplement, whatever. And then he'd do an echo again in like 1 to 2 years. And like, he would show them the improvement in their ejection fraction. And so many people were so happy with him. That guy was 42 and is retired now. That's the peak of his game, right? So for him, I think he ended up going into real estate. And it's sad because he was an excellent cardiologist, and there's nobody else like him I can send patients to. The other cardiologists I send people to, they work for a big corporation, and for them, they're clocking in and clocking out. They don't really have that same level of care. So I think this is a great time for everyone to consider expanding their skill set, trying something new, trying to do something else if you want to, and you get to help people, and you get paid well, and it's just a good idea. So if that sounds good to you, please let us know how we can help you. If you look at how heavily surgery is being pushed, and I've seen this with my own eyes, like I would see a surgeon join a health group, right? And they join a hospital corporation, and what happens? The hospital corporation gives them 2 years of salary. So they move their family to the place, they buy a house, they're getting 2 years of salary paid out. And then on the third year, they convert over to RVU only earnings. And then their earnings like drop by like 30%, because they were getting paid no matter what before with salary, because actually the government actually sponsors some of that money to do that. And then now they're basically on production. Well, guess what? All those RVUs, they got to make those RVUs to get paid. And that's why you see so many of the surgeons just kind of pushing so hard for surgery. I know all of us here in anesthesia probably know of at least one surgeon that operates on anything. Isn't that true? I mean, how many times? I know one of the hospitals that both Jennifer and I worked at, we had this guy, and he was a GI guy. And it doesn't matter what happened. Everybody was getting a scope. The guy's in the ICU on death's door, on like 5 pressors, but now he needs a scope. It doesn't matter the fact that, he's critically ill, and even transporting him would be a risk to his life. Nope. He's got to get the scope, because the guy needs the RVUs, because he got to pay for his lifestyle. His wife is demanding or whatever. And I'm not here to judge, because everybody has their own life, but the system is set up to prioritize the patients last, prioritize the providers last. And basically, everybody is essentially stretching to survive. And it's not a sustainable model. And so what you see in countries in South America and Asia is that they have a 2-tiered or 3-tiered healthcare system. And now in the US, you have the development of a 2-tiered system. I believe that chiropractors and med spas are going to be the forefront of the cash-based system in America. And so whether you have a med spa or whether you're working with a chiropractor, like, this is what you see. Chiropractors now are integrating with hormones. They're doing all sorts of new therapies, and more practitioners are working with chiropractors because they have these huge cash-paying patient bases that are just sitting there asking for services. And then basically you can walk in there and say, hey, I can help your knee pain. You have knee pain, but you don't want to have surgery. You can walk to Walmart and see patients who have pain struggling. And I will tell you that most of those people, are more than happy to pay $500 for an injection that will take away their pain temporarily and also help heal them, versus paying, tens of thousands of dollars for a surgery that may or may not help them long term, that has very high risk. Remember, if you have a knee replacement, your risk of cardiovascular events, including heart attack and stroke, is 9 times higher with that surgery. 9 times. It's not like it's a small thing, but they don't ever really mention that, do they? But anyway, so, like by offering these services, you'll be able to help so many people. And if that's something that is cool and you're interested in that, let me know. Happy to help however I can. And then what's the best and most rewarding thing is when you can take someone who is literally struggling to walk because their knee hurts so bad, and you can, by doing a series of PRP or PRFM injections into their knee, which is very simple to do, you can deliver them to a place where their knee is no longer hurting, and they can walk and they can play with their grandkids and they can do all sorts. There is no level of description that I can give you as to how good that feels, because that's why you went into medicine, right? Like, you went in to heal people. Unfortunately, the government system, the pharma system, the whatever, mega hospital corporation system, all put their interests in front of, what our main job is, and has clouded that because we have this third party payer stuff going on, and just what a mess, right? But the ultimate deal is that there's a lot of people that need help and they're happy to pay for it. And chiropractors have a list of all of them. And to work with a chiropractor takes no more than sending out a few letters. We had a lady named Stephanie Ware, who actually was part of the aesthetic training, and she wanted to find a new office space. And I said, hey, don't go out and rent this really expensive office space. Don't take on all this overhead, because sometimes if you go rent your space, you could be paying $3,000 a month times 5 years. Like, that could be your lease. It's a huge commitment. Don't do that. Go send out these letters to all the chiropractors in your area. I showed her where to get the database for her state. And if you need help with that, just let me know. I either have a database of chiropractors you can use, or you can go to like the local state and do a search for chiropractic roster, state name, get a list of chiropractors, send them out a letter saying, hey, my name's Angela Davidson. I'm a CRNA. I have trained with the American Arthritis Foundation. I do joint injections, regenerative medicine. I wonder if that would be of interest to you and your patients. I'd love to talk to you more about it. If it is, give me a call or text. Here's my number. Hope you're having a great day. Nothing more than that. You send out 10 letters, you'll get 2 replies. So for every 10, so we roughly see 20 to 30% reply rate. And we'll happen to have some great conversations with some interesting people. Some of them will be right for you. Some of them won't be right for you, but you will have an opportunity to basically practice a new form of medicine that you have the skill set already to do. It's not hard. Like, if you can drop a central line in someone, if you can try like float a swan, doing a knee injection is like, it's like shooting a barn with a shotgun. Like, it's so much easier, So if that's something that sounds interesting, please feel free to reach out to us. The one thing about pain management is that, I know some people are like, oh, don't teach people pain management. Like, number one, pain management isn't a field controlled by anesthesia. Some people may say, hey, it should be that way, but the reality is pain management has never been controlled by anesthesia. And it's kind of like aesthetic medicine in the regards that there are many different specialties that participate in pain management. And in fact, one of the biggest specialties is kind of a specialty that is somewhat unknown to a lot of people, which is physical medicine and rehabilitation. A lot of those guys do pain management. There's also psychiatry that does pain management, and psychology does pain management. And so there's different types of people that are involved in it. But the reason why pain management is one of the most interesting fields to work in is that there's always such a demand. You're never gonna, like, you could run down to Target or whatever, like you run down to a busy store in your neighborhood, and you will find somebody who probably needs pain management. It just, there's so many people that are aging. If you look at the demographics in the US, you can see the population is aging, and I think it's by 2030, every baby boomer will be retired by that time. So just in a matter of a few years from now, all the baby boomers are going to be retired, and all of them need to have help. And there's just not enough people to help them. And there's definitely not enough people that are interested in learning about things that truly help them, not so much things that are promoted by mainstream medicine. And this is, I'm like, take this with a grain of salt, but like for a lot of the people that are, for example, in orthopedics, you start out in orthopedics and, you're in your residency, you're going to start to meet reps. The reps are going to start to build relationships with you. You get out to your practice. You may be working for a group practice initially because most orthopedic surgeons don't have enough money to start their own practice immediately. So working in a group, the reps are talking to them. Their only continuing education they're getting anymore is from the reps. They're being invited to these little conferences all over the world. Well, guess what? Those conferences are very much focused on promoting surgery and using the products from the reps. So their entire world becomes just this one viewpoint, like surgery, 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 surgery. And the reality is that meanwhile, there's literature showing there's so many alternatives to surgery out there. Many times it's a willful negligence or just the fact that people just don't have time. If you're an orthopedic surgeon, you probably are really busy doing surgery all day. Do you really have an interest in learning how to extract PRFM and mold it to someone's, mold the PRFM into, a healing membrane that helps somebody, maybe not. Maybe you just rather do another knee replacement because you already know how to do it so easily. And, your best friend, the rep, is there helping you, I'm not saying it's right or wrong and I'm not here to judge, but like, that's the way our system works, And if you learn these skill sets and you're going out there and you're basically helping people, whether it's through doing headache blocks to help people with headaches, doing, joint injections with the patient's own blood derivatives that can heal them, you can add value. And the thing is that the more value you add, the more money that you'll get back in return. And that allows you to be safe, because what happens if your anesthesia group comes to you and says, hey, turns out the hospital is cutting our contract and everybody's got to take a 20% pay cut. Well, you're not just taking a 20% pay cut. You haven't been paid for the 30% pay increase that you should have got just to keep your money the same for the last 3 years. Now you're taking a 20%. Well, now you're down 50%. So you're making 50% less money in terms of value of dollars than you did 3 years ago. And I'm seeing this more and more. Like I have colleagues that reach out to me and say, hey, I work for, I won't say the name of the company, but it's like a huge health system in California that you probably have heard of. And they're cutting their salaries by 10 to 15%, despite the fact that they're seeing more patients than ever before. The documentation requirements are higher than ever before. And all of the cost of everything, and particularly in California, are going up. It just doesn't make sense. And so I think it's wise, at the very least, to have some kind of alternative for yourself to have on the back end, something else. It doesn't have to be this, it could be something else, but please just consider. I think if there's one thing I could say is that a lot of us have a syndrome. We have just me-itis, right? Like you think because you have always been with you that you don't have these amazing abilities. But if you were to sit down and compare yourself to the average person on the street, what you'd find is that your technical abilities are so high compared to the average person. And it's easy for us to get confused and think they're like, hey, I'm just another average person. I've got to deal with this stuff. I've got to do what the nurse manager tells me to do. I got to do with the, whatever anesthesiologist tells me what to do. No, you have options. You've always had options. The thing is that the system doesn't want you to know you have options for a lot of reasons. But number one is they want to keep you there, right? Just ask your anesthesia group. Do they really want you to leave? Of course not. They want you to get paid less and work harder and keep doing that over and over until you're burned out or you die. It's sad but true, but that's just the way it is. And I don't mean to talk down to anybody's anesthesia group or anything like that. And it's not necessarily even their fault, because the anesthesia groups, where are they getting the money from? The hospital corporations. And where do the hospitals corporation get their money from? They get money from the insurance and the government. And the government basically sets these plans, which are then executed by both the government and the insurance. And so it's basically top-down controlled. You got to have another solution. Whatever it is, look into it. And if there's anything we can do to help you out, that's what we're all about at Platelet.